discuss on. You know, diabetes is 1 and 2. Type 1 is only 10%. Mostly the type 2 diabetes, which is 90%. And type 2 diabetes, either it is a common metabolic defect. The common myth in the society is that diabetes means sugar. No, absolutely it is a myth. Diabetes is a common metabolic disease, and most danger is your most danger is our this triglyceride. So that's why now the even diabetes mellitus name has been changed. Saying don't say diabetes mellitus, it is a diabetes lipidus. Because whole problem is due to lipids and atherogenesis. And so many slides, I will prove that this is the not sugar is more danger. It is the lipids is the more danger. And whole type 2 diabetes mostly obesity acquired, and it is a lifestyle disease. So intra-abdominal obesity with insulin resistance leading to all this and CVD, so both are interrelated. So every day, every home, every house now diabetes is coming up, and it is a basically type 1 diabetes means there is a beta cell is not functioning and properly secreting the adequate insulin. Whether a type 2 diabetes, it is the peripheral receptor is not active, so there is a insulin resistance. So most common cause of resistance is the obesity and lifestyle, so leading to this. Very important that's why it is been labeled as CAD equivalent. Diabetes, if you are having coronary artery disease or if you are having diabetes, both are equivalent. The prognosis is going on increasing, and every day it is not going to hamper your heart. So leading to insulin resistance and visceral obesity, leading to free fatty acids, and all this dyslipidemia, hypertension will lead to further atherosclerosis. Now, how happen? Atherosclerosis we all know either platelet, atherosclerotic pattern, and increased response to vascular injury will lead to further atherosclerosis diabetes. So our target is that. Is it a atherosclerosis gradually? Is a long term? Is a normal sequelae of this? There is a microvascular and macrovascular complication of diabetes. It's a part of that. Now, everything should be talked on the evidence base, and most valid study is the UKPDS. This is in United Kingdom. This study was done in the whether this diabetes, every increase in death of fatal myocardial infarction (CAV), so all three circulation, cerebrovascular circulation, cardiovascular circulation, renovascular circulation, and retinal circulation is hugely affected by the diabetes, and both due to the atherosclerosis. And your HOPE study, heart outcome prevention evaluation study, was a famous study whether the cardiovascular risk was one of the major factor was the diabetes. So whenever there is a complications, coronary artery, myocardial, sudden death, dysfunction, stroke, hugely complication in the diabetes. Whenever there is an increased rate of heart disease, people with diabetes, almost 75% death, directly or indirectly, will lead to cardiovascular system. And the 1 year mortality following is myocardial infarction in diabetes 44, then the 37 in women, and cardiovascular is the most common cause of the healthcare accident. So how much is one organ will go, second organ will third organ will go. So gradually it will important. So always is the cause of this. So simple in clinics always we say to keep our tape and AC in South Asian populations is a huge. In earlier days, during time of married and grooms, when there is a bridegrooms have a basically big, it was a sign of prosperity. And earlier our forefather was saying कि उसी घर में शादी तो जहाँ पेट अच्छा रहना चाहिए, खाया पिया घर का. But now the things concept has been changed. खाया पिया घर का मतलब कि जल्दी चला जाएगा. So this is the not always a good of sign. It is always a bad sign. And look for the metabolic syndrome. We have done in our central hospital so many studies. In our one of my postgraduate is doing on metabolic syndrome. And look, every case is his case. He is saying, someone, are you seeing the metabolic syndrome? Every day saying, sir, ये तो criteria fulfill कर रहा है. So obesity, hyperlipidemia, hypertension, every woman of 50 hypertension in our cardiovascular clinic, we are seeing one tape and one weight machine fulfilling and lipid profile, everything is this. So no metabolic syndrome with metabolic syndrome, huge mortality and difference is there. Heart failure, we know the SOLVE trial, HOPE trial, and all these have proved that diabetes are more prone for failure. And there is not a single mechanism, there is multiple mechanisms. Is there. Similarly, album mass all will change more in case of your this. Now the most common there is advancement in changing HbA1c. Earlier it was a blood sugar fasting PP, urine sugar, then HbA1c. Now glucose, glucose variable test, new software based domiciliary treatment, advanced treatment. So many research is going on how to combat for this test for glycemic control and diabetes. And look, more than 10 of HbA1c. What always there is a risk of the death per year. So this is the circulation data of that. This is the last 10 years we are following HbA1c monitoring for our patients regarding this. So there is a highly strong data with heart failure in driving. Glycemic has been shown to reduce the complications by various studies. Now the second part is hypertension. There is a hypertension in 60 to 80% with diabetes, and always diabetes, hypertension carried a cardiovascular of this. So many cases of retinopathy when college there. So many cases before DFA, whenever you are saying, we are checking 170 by 90 BP. Most of the diabetes either due to ignorance, first time presented with vision loss or some sort of vision. Some are presented with stroke, some are presented with mitral infarction, some are presented with knee. So always it is a bad prognosis when there is a combination of this. And 3/4 of the diabetes, existing diabetes with hypertension. So this is the challenge that we have to cut off the course of diabetes, hypertension. What data to maintain? How much maintain so that there should not be go on the other target organ damage initially. And our urologic trial, ABCD trial I will mention especially that when there is a ABCD type, appropriate blood pressure in diabetes trial, AC inhibitors have decreased much incidence of CV in long-acting than the long-acting cancer child. But in facet trial, where the phosphonolipid versus amlodipine, there was a greater decrease in cardiovascular mark in if we are combining the AC inhibitor plus calcium channel blocker. So we are practically prescribing all the three. When the AC inhibitor, now it is no doubt about it. Last decade it was being debated. Now it is the treatment of choice for AC inhibitors with ARVs in early, so that we can prevent the future complication. Here the reduction of diabetes. No diabetes with diabetes. You see the when there is a CV mortality and a stroke, how much it is in 60 to 70% of this. Regarding beta blockers in diabetes, earlier there was a notion no beta blocker should be used, like propranolol. When there was a old generation beta blocker, there was a chance of masking of the glycemic hypoglycemia episode. So we are not using the beta blockers for and afraid of that. But now the carvedilol, bisoprolol or newer generation beta blocker is safe, and that has been proved for various trials that the outcome is better. Regarding AC inhibitors, because microalbuminuria is one indirectly significant risk factor for CVD. and AC inhibitor are recommended for all patients with diabetes and hypertension. With type 2 hypertension, AC inhibitor have a significant lower risk of this. So AC inhibitor is the no choice. Only thing is that it should be not, if there is a huge hypertension, there should not be bilateral renal artery stenosis. If it is a secondary hypertension, we have to follow up the then and then. And HOPE trials, it is a basically, it is a last 12 year already been debated, so many discussed. It is a very good trial outcome with this. And in diabetes, if we are using the ramipril versus placebo, you see the reduction of this is the your placebo versus the ramipril. So ramipril is now a well established treatment for this. Now for common questions, common thing is that how much BP we have to keep a diabetes. I am a diabetes. How much BP my should be? What should be lower? Normal we are labeling 140 by 90 above is a hypertension. But in diabetes, even lower is better. Around 125 by 70 are recommended for people who have already proteinuria. But at target, if we are satisfied, if we are achieving 130 by 80. But it should not be better, because higher the blood pressure, always safety will be not. So 130 by 80 should be our target. Similarly, what if a patient is CVD is increasing diabetes, if he also is smoke, like 3 times more there will be a CV risk in patients with diabetes with this. So think deadly combination of diabetes, hypertension, smoking, and then the God will save. And in addition to all that, always target is how much dyslipidemia. What should be our cholesterol level? So many patients are now himself will ask, my LDL is this, my HDL this, how much we have to keep it there. So always triglyceride. In next slide I will show how much our target should be. Yes, if there is a LDL less than 100, it is ideal. Triglyceride less than 150, it is ideal. And more than HDL 40 should be, even women we are calling 40. 40 above is there. So since if it is the over already big scope of that events, then our target is lower the better. Even 70 aggressive cholesterol control should be our target, and we have to give in this maintaining around 100 is satisfactory. Now we have discussed diabetes, hypertension, and thrombosis. Main is the platelet problem. Antiplatelet recommendation is around what we are calling 75 to 150 milligram per day. And 2 types of prevention generally for any disease: primary prevention and secondary prevention. Primary preventions in type 1 or 2 who are more than 40 years or additional risk factor for the CVD, hypertension is smoking. And secondary prevention in if the CVA is already there, like you post PTCA, post bypass, post MI, post EM. So both in there. Primary prevention, there was one message was there in last 2-3 years that every day in breakfast we have to take 1 tablet of aspirin and atorvastatin to prevent this. But that was not EMS, because we have to go for the risk stratification and then we have to follow the secondary prevention of this. ASA is not recommended if it is the age is less than 30. And other antiplatelet maybe if ASA is contraindicated. So always primary what we are following more than 50 years, then we have to go for that. And atherosclerosis events, in particularly in this, always those aspirin group versus non-aspirin group. Look, the always there is a mortality increase is that higher in this time. So always aspirin is simple tablet at around more than 50. Here 40 was written. Above 50 plus A. If there is a always we have to give. Something more challenges in diabetes with coronary artery disease is that how it differs from the others. Because CAD in the diabetes is a multivessel disease and it is the more distal, difficult to revascularize. Even if the PCI, it is the restenosis of metal stent, then the drug-eluting stent. Now the biological stenting is coming. So gradually it is more difficult. Even bypass surgery was very operative period. Healing problem is there. Post-operative long-term outcome is there. Our few patients post-operative, our patient were 35-40% LVM, more than 10 hospitalization per year. So it is increasing even after revascularization. The chances is the quality of life will be there always. So and besides in early coronary accident, it is always a challenge for the patient. So the whole long-term diabetes outcomes is always is better prevented. How it should not happen, because in spite of all these things, we are not going to get optimal attach, or we are not going to completely reduce the morbidity. Regarding the cardiac indication, when we have to go for the testing, if typical case, what we are doing in our hospital, no problem. When we are getting a diabetes with hypertension, we are for one time thoroughly doing the risk stratification through the ECG, followed by echocardiography, electrocardiography, and all their risk factors, dyslipidemia, hypertension, smoking. This changes for routine urine test, for one basic test, and followed by other tested of this. So screening of the diabetes is very important. That should be properly registered, thoroughly followed, and including eye, kidney, heart, and regular checkup. So many patients are to be educated properly, proper diet management, and their registration should be fully maintained. And it will be better if whole Southeastern Railway should have one diabetic registry, that we can combine that, we can follow their name and this, so that if we can stop them in early phase of the person, because many have lost the limbs, we have said amputated, and then the huge burden on that. If we can prevent ischemia, we can prevent the angioplasty. We are getting lakhs of rupees for angioplasty, and even after angioplasty and bypass, we are not getting the optimal result. Same failure, same type of this. Similarly, it will damage the kidney. It will huge loss for the revenue for the successive years for years, and the quality of life is less. So always it is better to have a registry and strongly follow them with proper early treatment with medicine and insulin, so that their target organ should not happen. Then the screening, what is the screening methodology for the various types and cost effectiveness should be here. Then the asymptomatic diabetes, what we are discussing. If it is asymptomatic diabetes, always it is better to have a early detection, early follow, and this. There are the recommendations when to do, and for more than 40 years plus, and assess the various of factors. And all the drugs who have been defined, that you have to go for risk stratification, and then you have to go for that. Now the message is last in the treatment of diabetes, largely focused mostly on the glycemic control. But it is not only the glycemic control, but the hyperlipidemia, institution of antithrombotic, all beneficial risk for these events in the diabetic will lead to them to appropriate treatment and comprehensive risk reduction of the CV events. So ladies and gentlemen, and respected sir, there is no such things in mild diabetes. There is never mild pregnancy. Always there is a diabetes, and we have to do aggressively for them with this. With this, we stop this thing and so basically the diabetes is